I'm MacKenzie and I'm going to be demonstrating NG insertion. Before I entered the room, I would check the doctor's orders on the client's chart, and I would gather all my supplies, bring them into the room with me. I'm going to provide privacy, and I'm going to wash my hands. I'm going to introduce myself to the client and check their name and date of birth on their armband and compare it to the chart. This is Jameson Allen, date of birth 11XXX. I would explain the procedure to the patient about the NG insertion so we can provide adequate nutrition for them at this time, and ask if they had any questions before we begin the procedure. Let them know that it would take about less than 10 minutes and that if they had any questions or concerns they could ask me. And I would let them know that it is uncomfortable, but I would do it as quickly and easily as possible. And if they had no other concerns, I would begin. I raise the bed. Actually going to begin by auscultating for bowel sounds. Make sure they are present in all 4 quadrants. Go ahead and raise the head of the bed to high Fowler's position. And I'm going to let my client know that they are more than welcome to raise this hand if at any time during the procedure they are at great discomfort or would like me to stop. And I would also be assessing the client's level of cooperation, whether or not they had a gag reflex present, and which nostril was more patent. You want to then put down a towel. Okay, patient. And the tissue. And prepare my already filled glass of water for my patient, just in case he needs it during it. Prepare my tape. Next, we'll put on clean gloves. And then I'll just set up a few more supplies. And I'm going to examine the tube for flaws or sharp points. I'm going to weight it around my hand to make sure that it's nice and flexible. And I will lubricate the very tip of it, about 3 to 5 inches of it. And I will begin insertion. And if at any time I feel great resistance, I can always withdraw and use the other nair. Or if the client is under extreme discomfort, I can always take a break. I need to remind them to swallow when I get to the pharynx. And I can let them do that. If it helps to drink water, they are more than allowed to do that. And if I think that it is coiled in the back of the throat, I can use a pen light and a tongue fixer to determine that. I can withdraw slightly and continue. So I'm going to insert. And I will have the client extend their neck while I'm doing so. Pushing gently. Swallow, 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 swallow. And I forgot to measure. Awesome. Before I inserted it, I would measure from the tip of the client's nose to their earlobe to their xiphoid process. I would mark that off with tape. So I would know how far to insert it. And then I would begin the insertion process. Inserting this one, this one, this one. When I reach the part I marked with the tape, I will then secure it to the client's nose temporarily. And at this point, I would check to make sure the placement was correct. I would ask the patient if they were having any trouble breathing. I would ask them to speak to me so I could determine if it accidentally went into the trachea instead of the esophagus. I would then actually push in 30 cc's of air into the tube, auscultating for the gastric bubble. At the same time, I could also withdraw 5 to 15 cc's of gastric contents and check the pH against a pH strip. And I could also, if I was truly concerned about it, also obtain an x-ray via doctor's order for the patient to ensure that it was placed in the proper area. I would then measure from the tip of the nose to the bottom of the tube and record this measurement. It's very important. Nothing can be put in or taken out of the tube without ensuring that the measurement is correct and the same to ensure proper placement. So at this time I would then attach, would retape to better suit the client's comfort with a securing device, and also secure it to the client's gown to make sure that it was not tugged on at any point to dislodge it from placement. I could then hook up the NG tube to suction or a feeding device if necessary. I would make sure the client stayed in mid-Fowlers for several hours after the procedure, and I would offer mouth care every 2 to 4 hours. I will now move into the demonstration of the feeding. I would check the expiration date. I would first check the doctor's orders, identify the client, wash my hands, explain the procedure, ask them if they had any questions or concerns, wash my hands, fed in high Fowlers and raised, check the expiration date on the type of the nutrition, and I would make sure that it was at room temperature. I would then, prior to administering the feeding, I would flush the tubing with 10 cc's of air, or of water, and then administer the feeding. I would do this via a plungeless syringe, actually, and I would be able to pour the formula into the syringe and then let it drain into the patient via gravity, not letting it go too fast so the patient does not become nauseated. And then I would, after the feeding, flush it with 30 cc's of water again. And I would make sure that the patient tolerated the feeding well and again stayed in mid-Fowlers after the administration of the feeding. Then for NG insertion, again I would check the doctor's orders, discontinuation. I would check the doctor's orders, identify myself to the patient, identify the patient. I would gather a towel and a tissue for the patient, which are actually already here. And then I would let the patient know that it is actually much less uncomfortable than the insertion of the NG tube. And I would pull continuously. I would clamp the end if it does not already have a plug in it. After I flushed it with 30 cc's of air, I would make sure that it remains clamped the entire time. And then I would pull continuously but gently the NG tube out of the nose, and then I would make sure to monitor the patient's tolerance of the procedure and ensure that further assessment of the GI tract was done to make sure that they were properly digesting and absorbing all the nutrition they had received after the discontinuation of the NG. I would document all of my findings, how the patient tolerated all of these procedures, anything concerning, I would report immediately to the physician, and then I would leave the patient, put the bed in lowest position, wheels locked, and call light within reach